Well, good morning. Thank you all for coming here. My name is Ryan Smith, respiratory therapist in the critical care here at Sunnybrook Hospital. I'm here today to present to you the therapeutic role of angiotensin receptor blockers in congestive heart failure. I would ask that you please hold your questions to the end. Briefly, we will do an introduction, review the pathophysiology of congestive heart failure and of angiotensin receptor blockers. We'll look at the methods used in my literature review, the results of which, and a discussion. Following this, there'll be a question period. So to begin, what is congestive heart failure? Quite simply, congestive heart failure is the clinical syndrome that results from any structural or functional cardiac disorder that impairs the ability of the left or right ventricle to fill or eject to sustain organs and tissues for life. Or in other words, it's the inability of the heart to meet the demands of the body. Causes of congestive heart failure are varied. The most common ones are displayed here, including coronary arteries disease, myocardial infarction, with or without subsequent myocardial remodeling, hypertension, and so forth. Mortality in CHF, as defined by the New York Heart Association Class 2 and 3, is 50 and 80% at 1 and 10 years respectively. The burden of CHF on healthcare is heavy, with an overall incidence of 2% in the population with increasing prevalence. Traditional pharmacotherapy for congestive heart failure is aimed at reducing cardiac chronotropy, reducing cardiac after and preload via diuresis, and vasodilation via calcium channel blockers and inhibition of the renin-angiotensin-aldosterone system, which we will discuss next. One of the hallmarks in the pathogenesis of congestive heart failure is the neurohormonal activation of the RAS. Shown in this slide, the main product of RAS is angiotensin II, which is formed when angiotensin I is cleaved by angiotensin converting enzyme, or ACE. Angiotensin II then acts on type 1 and type 2 receptors. AT1 receptors are located in a variety of tissues, found in the cardiovascular, renal, endocrine, and nervous systems. Expression of this receptor leads to deleterious effects in the body, such as increased LDL cholesterol transport and deposition, decreased endothelial function, vasoconstriction, edema, and so forth. By contrast, AT2 stimulation mediates vasodilation, decreased renal tubular sodium reabsorption, inhibition of fibroblast proliferation, and improved endothelial function. Thus it follows that selective blockade of systemic AT1 receptors via angiotensin II receptor blockers has given rise to much interest in CHF pharmacotherapy in the last decade. I performed a literature review, starting with a Medline search for highly powered randomized controlled trials comparing ARB monotherapy to placebo, ARB versus ACE inhibitors, and ARB plus ACE inhibitors to placebo in congestive heart failure from 2000 to 2009. 7 trials were identified. Concomitant with this, I searched for systematic and meta-analyses and consensus guidelines in CHF in the Cochrane database. The first trial identified was the ELITE II from 2000. It was a large, multinational, double-blinded randomized controlled trial comparing captopril and losartan. The patient population was quite sick, with a very decreased ejection fraction, and very elderly, with a median age of 71.5 years. All-cause mortality was found to be equivalent in both arms. There was, however, a significant reduction in therapy discontinuation in the ARB cohort. In other words, losartan was well tolerated. Critical appraisal of this trial reveals that the ARB dose was quite low at only 50 milligrams of losartan. Also, the follow-up was quite short, only 1.6 years. Here I've put up the Kaplan-Meier plot for all-cause mortality. We find that the hazard ratio, unadjusted as reported by the authors, is 1.13 in favor of captopril. it is possible that had follow-up been longer, there might have been an increased hazard ratio favoring captopril. Subsequently, in 2001, Cohen et al. Published the VAL-HEF study. It was a similar cohort of patients, this time larger with an N over 5,000, who were randomized to valsartan versus placebo. Again, there was no difference in all-cause mortality. However, there was an increase in morbidity in the subgroup of patients who received ACE inhibitor and ARB therapy. It is important to note that 92.7% of patients who were enrolled in the study were already on ACE inhibitors. A strength of the VAL-HEF study was that it was the first ARB study adequately powered to evaluate a mortality difference, even though it was negative. Next, and also from 2001, is the OPTIMAL study. Nearly 5,500 post-MI patients were randomized to ACE inhibitor versus ARB monotherapy. This study warrants mention, as the neuroendocrine pathogenesis and empiric pharmacotherapy of MI and CHF are similar. There was no difference to all-cause mortality, and thus ARB was seen as an effective substitute when ACE inhibitors are not tolerated in the post-MI patient cohort. Next, we come to the VALIANT trial, published in a very high-impact journal with an N of nearly 15,000 patients. This cohort was randomized to ACE inhibitor monotherapy, ARB monotherapy, or ACE plus ARB combination therapy. There was no difference to all-cause mortality. However, the ARB arm was significantly better tolerated, with 3.8% fewer patients discontinuing their medications. This highly powered multi-center trial reinforced that ARB, in this case valsartan, was as effective as captopril in the reduction of morbidity or mortality in the MI and CHF cohort, and could be considered an effective alternative when ACE inhibitors are not tolerated. Furthermore, in agreement with previous studies, the combination ACE and ARB therapy showed statistically significant higher incidence of hypotension. In 2003, Pfeffer et al. Published the CHARM overall study, again in a high-impact journal. A cohort of 7,600 CHF patients were randomized to receive the ARB candesartan or placebo. The patients were then stratified at randomization to an ejection fraction of greater than 40%, or the CHARM preserved arm, an ejection fraction of 40% or lower and being treated already with an ACE inhibitor, the CHARM added arm, or 40% or lower and not being treated with any ACE inhibitors because of previous ACE inhibitors intolerance. Within the CHARM added arm, all-cause mortality was shown to be statistically significantly lower in the treatment versus placebo group. This is in contraindication to the aforementioned VALIANT and VAL-HEF studies, albeit a 2% difference. Time to cardiovascular death and hospital admission for CHF was significantly reduced in the treatment arm versus placebo, which has been reinforced by previous and subsequent studies. But most importantly, the CHARM alternative study demonstrated that ARB was equally as efficacious a choice in AT2 blockade when ACE inhibitors are not well tolerated in the CHF cohort. Finally, we come to the ON-TARGET study published recently in 2008. This cohort of nearly 26,000 patients presented with cardiovascular insufficiency, the most common causes shown here. These patients were randomized to receive either ACE inhibitor or ARB monotherapy, or a combination of both. There was no statistically significant difference in mortality. However, and in agreement with previously mentioned studies, discontinuation of the treatment drug was highest in the combination therapy arm, the most common adverse effects being, again, hypotension and angioedema. Further, renal decompensation was statistically significantly higher in the combination therapy group.